that we have an adult genetics clinic. Excellent. I guess maybe the trainees don't. Yeah, so we started that about 11 years ago. I like to remind people to think about that. So what I'm going to do today is to just give you kind of a general overview of osteoporosis, and we'll talk about treatment, and then controversies, and how long to treat, are these medications dangerous, and et cetera. So first, starting with definition, osteoporosis is a diffuse skeletal condition characterized by reduced bone strength and increased susceptibility to fracture. So here you can see nice sturdy bone up top and the osteoporotic bone here, so the individual trabeculae are thinner. There's a little microfracture here. Notice that low bone density is not in the definition. So the diagnosis, and this has changed in 2010. We used to say that any fragility fracture made the diagnosis of osteoporosis, but now, as of 2010, the consensus is that if your patient has a compression fracture of the spine, and it can be asymptomatic and just discovered on X-ray, or a hip fracture, that makes the diagnosis of osteoporosis. You don't need any other diagnosis, any other test or anything. Or you can use the WHO criteria based on DEXA, and remember that these are for women. I had some information about men because there's some men in the audience, and some trainees treat men as well. So these criteria pertain only to postmenopausal women and men over 50. And I'm not going to read these to you, but just to remind you that osteoporosis is diagnosed with a T-score, which is a comparison of bone mineral density to Young's normals at peak bone mass, either at the hip or spine. And for every -1 on the T-score, the risk of fracture goes up 2 to 3-fold over and above age-matched controls, which is kind of a hard number to get your head around. So a T-score of -3 would be 2 to the 3rd to 8-fold increased risk of fracture over age-matched controls. And what we really want to know is we want to be able to tell our patients what's your absolute risk of fracture. And we're going to talk about that in a minute. Now, osteoporosis, of course, does occur in children and younger women, premenopausal women. The diagnosis is different in premenopausal women. So we need a fragility fracture and a Z-score less than -2. So the Z-score is standard deviation away from age-matched controls. And so if the Z-score is low, less than -2.0, but there's no fracture, we call it low peak bone mass or low bone mass for age. So again, you have to have a fracture and a Z-score less than -2 in a young person. The T-score does have some limitations, so not all who have osteoporosis have a T-score less than -2.5. In fact, half of hip fracture patients do not have osteoporosis by T-score. It doesn't mean that they don't have osteoporosis, it means that it's not a perfect measure. And given a particular T-score, the absolute risk of fracture increases with age, and I'm going to show you that in just a minute. Prior fracture, parental history of hip fracture, glucocorticoid use, rheumatoid arthritis, smoking, and excess alcohol. So here's an illustration of one of those points that I made. So this is number of hip fracture patients, and this smooth line is postmenopausal women, actually 8,000 of them, and their bone mineral density with the T-score is listed down here. And those in the bars are those who had a hip fracture. And I think that you can see there's a huge overlap. And those in the shaded bars here are those who do not have osteoporosis by T-score. So more than half do not have osteoporosis by T-score. And so, again, it's just not a perfect measure. We still do it DEXA, so we have something to follow. And here's another point that I mentioned, that the absolute risk of fracture increases with increasing age. So here we have absolute risk of fracture and increasingly worse T-score and age here. So notice that under age 40, even with so we've used the Z-score there, but the Z-score and T-score at 40 are pretty similar, of -3.5, the risk of fracture really isn't increased yet. And so here we have a newly postmenopausal woman of 50 with a T-score of -2.8. Her absolute risk of fracture is about 13% in 10 years. But her mother, who's 80, with the same exact DEXA report, her absolute risk of fracture is 30%. So age makes a big difference. And you can use this to help reassure young women, meaning in the 50s, that their risk of fracture is not that high. So why isn't the T-score more exact predictor of fracture? It certainly would be a lot more convenient if it were. And the reason is that we're trying to estimate bone strength, and bone strength is composed of bone mineral density, which is what we're measuring, and bone quality. And we can measure bone quality by research tools like high-resolution MRI and peripheral CAT scan, but we don't have a clinical tool to measure that yet. So changes in bone quality that occur with age make the bone less strong. So if the bone becomes less flexible, more brittle, and there's less trabecular connectivity, which I showed you in the first slide. So because of the underdiagnosis of osteoporosis and the fact that the DEXA is not sensitive enough, along with the new guidelines in 2010 came the recommendation to do T-spine X-rays. And this has been amazing to me how many people I find who have a compression fracture that is totally silent. So a T-spine, and I should mention you can do a plain T-spine X-ray, or you can ask the DEXA person to do VFA, vertebral fracture assessment. And they basically, along with the DEXA, and our machine at Redwood can do this. And there's actually an order in Epic, believe it or not. So VFA, and it's just a lateral spine picture. Quality is actually pretty good, and you can see if there are compression fractures there. So the recommendation, again, by the National Osteoporosis Foundation to do a T-spine X-ray are for women over 70, men over 80 with a T-score of less than -1.0. So -1.1, which you look at and say, oh, that's nothing. You should still do a T-spine X-ray because that patient may have compression fractures, and then that makes the diagnosis osteoporosis. Women 65 to 69, T-score less than -1.5. And also postmenopausal women who have had a fragility fracture. So your patient who falls and breaks her wrist, we used to call that osteoporosis, we don't anymore, but if she also has a compression fracture in the spine, then she has a diagnosis of osteoporosis. Excuse me, a height loss of 1.5 inches. So your people who do your intake in the clinic should measure height. You know, some clinics, I have to ask every new medical assistant, did you actually measure the height or did you ask the patient? And more times than not, if you don't absolutely require it and insist on it, they will just ask the patient. So we want to measure the height, and 1.5 inches lost from stated peak height is enough to do a T-spine X-ray. Or if you're following the patient and you've documented a height loss of 0.8 inches, that's a reason to do an X-ray to look for compression fractures and chronic glucocorticoid use. So the osteoporosis prevalence has actually gone down in the past 15 years or so. So comparing NHANES 3 around 1990 to NHANES more recently, the prevalence of osteoporosis has gone down 7% in the U.S., which is actually pretty significant. And hip fractures have gone down from 1,000 per 100,000 patient years to 695. So hip fractures have gone down by 1/3 in this country. And this is attributable to osteoporosis. So I ask you to keep this in mind as we get to potential side effects, that this is a public health benefit that the bisphosphonates have given us. So hip fracture, of course, is one of the most morbid fractures. Only 25% of women go back to the independent lives they had before the fracture. But also acute clinical vertebral fracture decreases survival as well. So here's hip survival and vertebral fracture. So risk factors for osteoporosis, I've already mentioned age, female gender, low body weight. Now, as it turns out, for a postmenopausal woman, under 127 pounds is a risk factor for osteoporosis, regardless of height, and certainly does not apply to young women, but low body weight is a risk factor. Genetics, so if your patient has had a parent with a hip fracture, that increases his or her risk tremendously. And so for those of you who treat osteoporosis, you have to get used to asking in your family history, did either of your parents break a hip? Caucasian women are more at risk. Falls, smoking, excess alcohol, which for women is considered to be more than 2 servings per day. Hypogonadism, of course, at any age, lifelong inactivity, poor calcium intake. One of the newer comers on the list here is chronic hyponatremia. and there's actually a mouse model for that. Elevated homocysteine in women, but not men. So for those of you who've been around for a while, you may remember that high homocysteine and treatments to lower it was very much lots of study and interest in it within the 10 years ago or so. And the studies did not show that reducing homocysteine levels reduced heart attack and stroke. But in those studies, they included bone density and incidence of a hip fracture. And in women, lowering homocysteine reduces the incidence of hip fractures. So I don't measure it on all of my patients, but if there's a patient who's not doing well, not improving as I expect, I may measure homocysteine. And then if it's elevated, high-dose B vitamins. So it's more than a multivitamin, but they're prescription combination B vitamins that you can use for this, and that will reduce the risk of fracture. So the highest risk of fracture is in those who have had a past fracture. So again, if you're going to treat women with osteoporosis, it's good to just remember every visit to ask them because they may have had a wrist fracture and just not mention it to you. So those who have an acute spine fracture, for example, almost 20% will have another acute spine fracture in the next year if we don't intervene. Medications are one of the main causes of secondary osteoporosis, and this includes the SSRIs. Glucocorticoids are the biggest offenders. Now for GYN, aromatase inhibitors are really deleterious for the bone, and Depo-Provera. Proton pump inhibitors, but not H2 blockers like ranitidine and TZDs, which are kind of out of favor now because they could cause heart failure and flash pulmonary edema. So a couple words about Depo-Provera. I could give a whole talk about this. There's so much data out there, but the bottom line is that the bone loss is greatest in the spine. The spine is trabecular bone; it's more metabolically active, and it's greatest in the first 6 months. And this is true for glucocorticoids as well. That the greatest rate of loss in the first 6 months, and then it kind of slows down, but the rate of loss continues. And the recovery of bone loss is best in the spine and in the youngest women, and is inversely related to duration. So there's studies that support every one of those points. So the newest study that I've been able to find was a study on 10 years of use from last year. Small number of patients, but not trivial. So 47 patients on Depo-Provera, 41 with an IUD. And in this study, they found that 68% of the Depo users had osteoporosis compared to 29% having low bone mass, which is more than double the rate of osteoporosis compared to the IUD users, and 10 times more in low bone mass. No fracture data yet, and yes.
Is that the upper IUD?
Yes. Yes, they did mention that, and I just looked at it yesterday, so I remember it was a copper IUD. Yeah, do you think that would make a difference in terms of the bones?
Well, I was just curious.
Oh, it's not hormonal.
Right.
Yeah, right, exactly. There are a million types of secondary osteoporosis. Just to remember, if your patient has osteogenesis imperfecta, or has cystic fibrosis, or inflammatory bowel disease, that she is at increased risk for osteoporosis. Okay, so now we're going to turn to osteoporosis treatment, and a couple words about evaluation for secondary causes, non-pharmacologic treatment, and then pharmacologic treatment. So after diagnosing osteoporosis, it's really important to evaluate for secondary causes. And that would be a comprehensive metabolic panel, not a basic metabolic panel. We had a patient in the hospital, it's been probably 10 years ago now, who was admitted to the orthopedic service with he had broken his tib-fib skiing. Okay, no big deal. That's not an osteoporotic fracture, and it wasn't healing. So he was on crutches for about 9 months, and then he fell and he broke his femur. So he was admitted to the hospital, and because we have an agreement with orthopedics that they're supposed to call endocrine consult if there's a suspicious fracture, we came in and evaluated. They had done only a basic metabolic panel because he was a 34-year-old guy. Why would you do a CMP? So we did a CMP and found his liver function studies were elevated. We did testosterone, which is part of the secondary evaluation, which was undetectable. He had no problems with decreased libido. As it turns out, his wife had no libido either, so they were well matched. But he turned out to have hemochromatosis. And he had actually seen a GI doctor who, strangely enough, hadn't measured hadn't measured iron studies. His liver function studies were elevated. So in that patient, he also had type 1 diabetes, which goes along with hemochromatosis. But in that patient, his hemochromatosis was presenting as fracture. And if, I don't know if it would have been diagnosed otherwise. And of course, the next thing to come is iron deposition in the heart and heart failure. So comprehensive metabolic panel, CBC, just getting an idea if there's any chronic problem going on here. So one thing that I specifically look for is low platelet count, which is associated with Gaucher disease. Gaucher disease patients can have infarcts in the bone. It's very much like a sickle cell patient. All right, TSH, we're looking for occult hyperthyroidism, 25-hydroxy-D to look for vitamin D deficiency, and very importantly, a spot urine calcium tricreatinine. The spot urine is a pretty good screen for hypercalciuria. If it's below 0.2, it's pretty specific for not being hypercalciuric. If it's over 0.2, then you should do a 24-hour urine. You say, oh, nobody likes to do 24-hour urine. But it's really important because 15% of women with osteoporosis have hypercalciuria. They have negative calcium balance, and you start loading them up with calcium but haven't found that, you could precipitate a kidney stone. And also, so we put them on thiazides that reduces calcium output in the urine and really helps bone. In fact, thiazides could be a treatment unto themselves for osteoporosis. That's how much it helps the bone. And in men, the association is even higher, 20%. And I do acetyl peptide, which I'm going to talk to you about in just a second, which is a marker of bone resorption in everybody because it can help you decide how long to treat. You need to think about celiac antibodies. And in patients with multiple fractures, of course, you always have to remember about malignancy, multiple myeloma, and any other malignancy can present, particularly breast cancer. I've learned over the years that breast cancer can literally be anything. And I can tell you an anecdote about that later if we have time. And in all, I mentioned doing a T-spine X-ray. So not only in patients who don't have osteoporosis, like I said, but those who do, you need to do a T-spine X-ray to look for your baseline number of fractures if you have any. So that along the way, if your patient has back pain, you'll have a baseline. Okay, so I used to talk a lot about vitamin D. I think everybody knows about vitamin D now. There is a little bit of controversy. The Institute of Medicine put the normal 25-hydroxy at 20. No one else in the world of bone, meaning the Endocrine Society, the International Society of Osteoporosis, agrees with that. So we all go by 30, and 40 is ideal for bone metabolism, calcium absorption, etc. Calcium is usually normal with vitamin D deficiency, and if it's significantly low, you can get secondary hyperparathyroidism. Calcium is normal, PTH is high, and that causes further bone resorption. So let's first talk about non-pharmacologic treatment. So calcium and vitamin D to treat osteoporosis. There's been a lot of sort of negative hype about calcium and vitamin D. There's no proof that that you need them. It's absolutely not true in patients with osteoporosis. Very, very well shown that you need calcium and vitamin D to do well. A few years ago, there was an association found between myocardial infarction and stroke with calcium supplements. That's been completely debunked. And vitamin D, 1,000 to 4,000 units a day, individualized to get your 25-hydroxy-D to 40 if possible. And then I usually check it once a year. Yes?
What's the importance of dividing the calcium?
Oh, so calcium, the GI tract can only absorb 500 to 600 milligrams of calcium at one time. So that's why it can. And we're going to talk about calcium again in just a minute. So this study is from a meta-analysis. Is a later one, in addition, by Bishop Ferrari, who's done a couple studies on this. So meta-analysis of about 14 different studies on this question of do calcium and vitamin D reduce fractures. And the answer is yes, 25% reduction in hip fracture just from calcium and vitamin D if you give at least 700 units of vitamin D. Now remember, the Women's Health Initiative only needs 400. So baby dose, I guess it was designed so, well before we realized that that's just not enough. And if you achieve a 25-hydroxy-D of at least 27, the fracture risk reduction is 25% for hip. and again, the best is 40. So calcium, what kind? So 1,000 to 1,200 milligrams. I ask patients 3 quick questions to get an idea of their dietary calcium. How much milk, yogurt, and cheese do you eat per day? So milk is 300 milligrams of calcium per cup. Yogurt, if it's regular, 300 milligrams per cup. If it's Greek, it's 400 milligrams per cup. Cheese is 200 milligrams per ounce. And in 10 seconds, I can know what the dietary calcium is. And I've found over the years that I can't predict, looking at my patient across from me, how much dietary calcium they take in. I've seen 84-year-old men who've taken a quart of milk a day, who've known that, and others who I would have thought probably had good dietary calcium have none. So you really need to ask. And those who get enough in the diet don't need a supplement. And that's really the way I prefer for patients to get it. Otherwise, calcium carbonate is best for most. It's the most easy to find. It's the cheapest. But if there's a decreased stomach acid, such as they're on a PPI, calcium citrate is best because the calcium citrate doesn't require acid to dissolve in the stomach. And the PPIs, of course, reduce stomach acid. Although, even if your patient's on a PPI, if they take calcium carbonate after a meal, the absorption is still pretty good. Vitamin D supplementation, I have a whole talk on just vitamin D and non-bone effects. So vitamin D is, making everybody vitamin D replete isn't going to cure all disease, but it has a role in many, if not most, systemic disorders. And this study just shows that vitamin D repletion reduces falls. Exercise, again, the whole hours of data on exercise. This is the bottom line way I like to think about it, that for our elderly patients, to avoid immobilization, bone loss. So when you're in bed rest, you lose 1% of your bone mass per week. So you think of our shock trauma patients. So to avoid that bed rest bone loss, people need to be on their feet for 8 hours a day, which doesn't sound like a lot maybe to some of us, but for elderly people, they're not on their feet 8 hours a day. They're sitting down and then they go and get a cup of tea and then come back. So we really need to encourage our patients, elderly ones particularly, to be more active. Walking does improve bone density, but the best is high impact. So for patients who are able to do a little bouncing, like jump rope, jumping jacks, that's the best. We learned this first from studies on vibrating platforms, and it turns out that really works well for sheep. Really increases the bone density. You can actually buy vibration platforms right now today. You go on the internet and you'll find them, but it turns out it didn't work so well in humans. So they had platforms, some that are such a fine vibration that you can't feel it, and others that you're holding on for dear life, and they just don't really work well. But you just have to do that kind of pounding. So walking is great exercise, but if your patient can add some impact, that will help more. And also weights. I recommend all my patients do weight training, not 3-pound weights, but weight training, because after menopause, and for men after 50, we all lose muscle mass, and it's pretty dramatic how much muscle we lose. Okay, so who are we going to treat pharmacologically? So according to the National Osteoporosis Foundation and Endocrine Society and ACE, we're going to treat all who have osteoporosis. And remember, these are postmenopausal women, men over 50. That means they've either had a hip fracture or spine fracture, even if it was asymptomatic, or they have a T-score less than -2.5 in the total hip, femoral, neck, or spine. And for low bone mass, we're going to use the FRAX tool, which I expect that most of you know about. FRAX, just Google FRAX, and up it pops. You first have to pick your ethnicity, your patient's ethnicity. So there are databases from people from all over the world. So there's a database from China, from Jordan, from some of the African countries. And if you play around with this tool a little bit, I usually do this in front of the patient so they can see what we're looking at. And then you have to insert the age, sex, height and weight over here, whether they've had a fracture, parental history of hip fracture. So you have to ask that, smoking, glucocorticoids, all the risk factors for osteoporosis. And then lastly, your femoral neck bone mineral density, press calculate. And these numbers here are, so this is 18% risk of any fracture in the next 10 years, and this is 3.7% for hip. And by general convention, we would use 20% risk for any fracture or 3% risk for hip fracture to treat. And this tool is very well validated over and over again to help decide who to treat the patients who do not have osteoporosis but low bone mass. And I think has really allowed us to not over-treat patients, which we were clearly, by today's criteria, over-treating people in the past. Okay, so pharmacologic agents, this is basically the list. We have the bisphosphonates, which are number 1, denosumab, Prolia, raloxifene, Evista, calcitonin, myocalcin, and then we have, and these are all anti-resorptive. Bone formation stimulators, other ones known as anabolic. We have 1, teriparatide, but a couple more in development that hopefully will be around in the near future. So this is sort of the bottom line of what these drugs do to reduce fractures. So alendronate Fosamax, the oldest, came out 21 years ago. There's still nothing better in terms of reduction of fracture risk. It's the only available generic, and I prescribe it as my number 1 if I have a really compliant patient. Risedronate, which is Actonel, also reduces all fractures, as does zoledronic acid. Reclamp, which is my number 1 if I have a patient who I think is going to be less than 100% compliant. Because it's an IV once a year. I know they've gotten it, and they're protected. Notice that ibandronate, which is Boniva, which has the best name of any drug for osteoporosis I could think of, and a great spokesperson in Sally Fields. Those of you who may have seen the ads a few years ago, it's not so much marketed these days, but notice that it's the only of the 4 bisphosphonates that does not reduce hip or non-spine fractures. And the drug reps get out there in the physicians' offices and promote their drug, and here are some samples, and they don't tell you, oh, well, this is the least effective. And if you look at Endocrine Society guidelines, it's not considered to be first-line treatment. And patient wants a once a month. Risedronate, Actonel has a once a month pill. Denosumab, Prolia also reduces all fractures. PTH Forteo is wonderful for the spine. It's the best drug for the spine. It does not reduce hip fracture risk. Down at the bottom, I have unbolded because I really don't ever use them, and because they're the least effective. Raloxifene only reduces spine fractures, less than all the bisphosphonates, no effect on non-spine or hip. Same with calcitonin. In fact, calcitonin may be coming off the market because there's a little association with cancers. And it's so ineffective that in the day when that's all we had in the 80s, that we gave it subcutaneously and it had some effect to this degree, but it's just obsolete at this point. Estrogen replacement shown again in the Women's Health Initiative, but many dozens of studies before that it is an effective treatment for osteoporosis. It has lost its FDA approval for treatment of osteoporosis, but if your patient is on full estrogen replacement therapy, she does not need another drug. We used to use other drugs, anti-resorptives with estrogen, but that's kind of gone out of favor. Okay, so just a couple words about bone turnover, just to have some awareness that bone formation and resorption are coupled. In any 1 year, you break down and reform about 10% of your skeleton. And so with that formation of new bone, you're repairing microfractures and getting fresh, healthy bone. And the turnover is very tightly regulated, lots and lots of players there. But the bottom line in terms of useful information from all that is resorption markers, acetyl peptide, which I mentioned I do in all patients at baseline. There's N-tylyl peptide also, which is a marker of bone breakdown. Older ones that are obsolete, you can still order them, but they're obsolete, pyridinium cross-linked hydroxyproline. And then bone formation markers, the bone-specific alkaline phosphatase, osteocalcin, P1CP, P1NP. You read the literature on osteoporosis, you'll see P1CP and P1NP, which are markers of new bone formation, used because they show an increase most quickly if you're using an anabolic agent. Okay, so just to illustrate how these can be useful, just so you see how they work. So this is acetyl peptide, bone breakdown marker, and bone-specific alkaline bone formation marker. So this line is alendronate, and this line is zoledronic acid. And so we can see that bone breakdown goes down very promptly. It's even earlier than 1 week after zoledronic acid, and then it stays down. So this is a single dose. 2 years, it's still down. So the way you can use this is if you have a baseline marker, You can say to your patient, well, we could even treat you every 2 years. So there's studies now going on to see if that has the same fracture protection. And then you follow the acetyl peptide, once a year or so, and if it remains suppressed, you may be able to forego that treatment and wait another year. Teriparatide, which is anabolic, just to demonstrate that the bone turnover markers go up, and generally we check bone-specific alk phos at either CTX or NTX at about 6 months. That confirms the patient's taking it, and it confirms that they're responding to it biochemically. Okay, so let's look at controversies. How long to continue bisphosphonates? And when we're thinking about this question, we need to know, well, how long do they continue to be effective? And what are the risks of long-term treatment? So there's not a lot of data on length of effectiveness, but the FLEX trial is probably the best data. So this is an alendronate, and we can see that bone density continues to go up over 10 years. And bone turnover markers continue to remain down. And fracture protection is not a good slide, I apologize. So this is in reduction of fractures in alendronate compared to placebo, and at 10 years in the FIT trial, which I'm going to show you in just a second, fracture protection continues. And that's pretty much the best, and this is the same study, just in a different format. So the fracture intervention trial, women were put on alendronate, and then after 5 years, the group was split. Half came off, and half stayed on it. And you can see what the bone density went down. But what we really care about is fractures. What happened with fractures? So there was no difference in clinical hip fractures in the second 5 years, but there was an increase in the discontinuation group in spine fractures. And so this is something you can just take into consideration as you're treating a patient. If she has baseline spine fractures, then you might want to continue her longer than 5 years, depending on how she does with treatment. This is just another discontinuation study with prosedronate, showing that after this was, I think, 3 years of treatment, and then stopping and looking at fractures in the following year. So fracture protection is continued for at least 2 years with the bisphosphonates in general. And so we use this when we're thinking, well, I'm going to stop this patient because I think she's done well, and I know that the bisphosphonates is going to be protected for another couple of years, so being off treatment. And I mentioned that zoledronic acid, one dose can maintain BMD for 2 years, but no fracture data yet. There have been in multiple studies shown now a reduction in all-cause mortality with zoledronic acid. And this does not seem to be a statistical fluke. It seems to be real. It's not reduced risk of heart attack or stroke. People are not dying less because they're not falling and breaking their hip and dying from that. It's really unknown why, but it does have a longevity benefit. Okay, so how long to continue? There's some evidence of efficacy up to 10 years, and so that's the upper limit of what we should use. Is 10 years, we have data for 10 years. And after discontinuation, fracture risk for the bisphosphonates persists for a year or two. So now what about the risks? These are side effects that were initially brought up that have not been confirmed. Atrial fibrillation is not increased with bisphosphonates. Esophageal cancer, GI side effects in placebo-controlled trials are not increased. Nephrotoxicity, although we see this in oncology patients, has not been seen in osteoporosis trials. Side effects that have been confirmed: bone pain, 5%. Iritis is very rare. I've seen one patient in my career, and then we're going to spend some time talking about atypical femur fractures and osteonecrosis of the jaw. I'm actually going to skip this. That was just the GI issues. This is just a study illustrating what I said about safety on the kidneys in the osteoporotic population. So this is 5,000 patients on zoledronic acid annually, and similar 5,000 on controls. And this is creatinine measured in a subset of patients. Note here that the placebo patients bump their creatinine at 10 days. So if this is your individual patient, you're probably going to be thinking that's the drug, but it was no difference. And this is creatinine over time. This is the postmenopausal group, so they're all losing kidney function over the course of 3 years. No difference in placebo compared to drug. Okay, atypical subtrochanteric femur fractures. So we knew about these from meetings and things for a couple of years before it kind of hit the press. And one day I came in and my secretary said, "Oh, did you hear about the fractures that the bisphosphonates are causing?" And I said, "Oh no, the phones are going to be ringing off the hook." And sure enough, they haven't stopped. And I spend about half of every visit trying to reassure patients that these medications I'm recommending are not toxic. So an atypical femur fracture is below the lesser trochanter, not the traditional femoral neck fracture or intertrochanteric fracture. They were first reported in 2007, and so this is lateral, this is medial, and the specific characteristics that make it atypical are there's sclerosis here laterally, and there's this beaking. And it's kind of a green stick fracture. It's not the typical common fracture we see in overall studies. And about 2/3 of patients on bone biopsy had low turnover, less metabolic activity going on in the bone. However, we know that bisphosphonates don't cause low turnover, and it's important if you read any of these studies to note that no baseline bone biopsies have been done. So this just shows what low turnover looks like. So this is a normal piece of bone, and all this is unmineralized osteoid, and the tetracycline labeling, you can see it fluoresces. Adynamic bone, there's nothing going on around the surface, and there's no fluorescence. And we know, I'm not going to read this to you, but to get a bisphosphonate approved requires bone biopsies at the beginning and at the end of a period of treatment, and not insignificant numbers. So for alendronate, 88 people on bisphosphonates, 71 on placebo, bone biopsies at the beginning, 1 year, 2 years, 3 years. We know that these drugs do not cause low turnover. However, about 5% of people have low turnover at baseline. And so whether the people who have atypical femur fractures have low turnover from the beginning, we don't know. This is what we do know about them. Who has them? We know that they've been on bisphosphonates a median duration of 7 years. They're more common in those under 65 than over 65. 2/3 of the people in case series don't have osteoporosis and have low bone mass that's so low we wouldn't even treat it today. So this is one important lesson to us, going forward, that by today's criteria, we were over-treating people in the past. And for the occasional woman I see who really wants to be on treatment, which is not so common these days, I tell her, you're more likely to have an atypical fracture because you don't have osteoporosis. 70% have a prodromal pain in the thigh, so you can do an X-ray and look for those precursor signs. About 28% are bilateral. Those who are on chronic glucocorticoids or PPIs, RA, or severely vitamin D deficient are more likely to have this. So this is the slide I showed you before, showing that typical hip fractures have gone down in a 10-year period from 1996 to 2006. In that same period of time, the atypical fractures have gone up. However, you may notice that it's a factor of 10 lower. So here we're talking about 800 per 100,000 patient years. Here we're talking about 30. Went up from 30 to 50 per 100,000 patient years. Order of magnitude different. So, and these are the bullet points that I tell my patients that are supported by data. In the worst case scenario, the risk of atypical fractures on chronic bisphosphonates is actually 1 in 500 over 5 years of treatment. And for every one of these that happens, 100 typical hip fractures are prevented. And that's what the data show. And that is a reassuring statement, I think, for most patients. Osteonecrosis of the jaw is exposed bone in the jaw for at least 8 weeks. If you don't know, our dentists at the University of Maryland described some of the first cases and have active research in this area. We know that it's rare with the osteoporosis doses of bisphosphonates, less than 5% of the total cases. And this was on the GWAN board exam once. I used to give a talk for the exam pro, if any of you know about that, and that was one of the questions on one of the exams. So 95% of the patients with ONJ have cancers and are getting higher doses of bisphosphonates. So not zoledronic acid once a year, but once a month. And so that predisposes to the ONJ. Spontaneous is, and this I tell patients these numbers, is 1 in 2,500 person years. So up to 1 in 2,500 to 1 in 10,000. So you tell them the worst case scenario, after 5 years, the risk is 1 in 500. And that's spontaneous ONJ. After tooth extraction is 1 in 200, so that's a little bit more. Most have no symptoms, or they can have pain. This is just what happens, the bone just kind of necroses. In my career of treating osteoporosis for the 25 years of focusing on, that's the main patient population I see. I've seen 3 cases of true, confirmed by our dentist, ONJ from osteoporotic drugs. All of them were on bisphosphonates longer than we use now. And we don't, and this is one of the reasons why intermittent treatment has really become the way we do things as opposed to continuous treatment. So there are guidelines from the Oral Maxillofacial Surgery Society. For those who have cancers, they're supposed to get their dental work done before they go on bisphosphonates. For those on orals, they don't need to do that. It's overkill. But if they're going to get implants, then we generally wait until they finish that. Duration of bisphosphonates. So this is from the NOF guidelines, and that is that we generally treat for 3 to 5 years, at least 3 years, because that's what the fracture reduction is based on, 3 years of treatment. And then after that, it needs to be individualized. And there's no simple algorithm, unfortunately. But we want to measure height as we're going along, assess for vertebral fractures. The patient develops back pain during the treatment. We want to assess to make sure they haven't had a new fracture. And for those who may remain at high risk of fracture after 3 to 5 years, we either continue with the bisphosphonate up to 10 years or change to teriparatide, or if a new anabolic comes out, change to one of those. And those who are at low to moderate fracture risk, stop treatment, check the DEXA annually, and then remembering that they're protected for at least 2 years, they can be off for 2 or 3 years, and then when the risk goes up again, they can start treatment again. When to use Prolia and Forteo. So I'm not going to go through this rank ligand pathway, but basically Forteo is PTH. And PTH, I've just mentioned previously that PTH is bad for the bones. It causes increased bone breakdown. But actually PTH has 2 opposite and not at all intuitive effects on the bone. So if you give a brief exposure to PTH, as in an injection of Forteo, it is anabolic to the osteoblast, causes osteoblasts to make new bone and recruit more osteoblasts, and you have excellent increase in bone density. If there's a prolonged exposure, as in hyperparathyroidism, primary, secondary, tertiary, PTH is up constantly. We stimulate the rank ligand, which causes osteoclasts to break bone down and causes bone loss. One very, very important point, if you take home, for those of you who treat osteoporosis, if you take home one point, I'd like it to be this, and that is that the effects of denosumab are completely reversible. So I've said several times now that with the bisphosphonates, you treat for a period of time and you stop, the benefits continue for at least a couple of years. With Prolia, completely reversible. And this, I think it's important to know, because this is one reason you don't put young people on Prolia, because they have to stay on it forever. So this is the cetyl peptide, which goes down with treatment, and then this is from a discontinuation study, the markers actually rebound higher. And so there was concern initially that you might actually have a worse fracture risk after stopping it. And as it turns out, the fracture risk was not sustained, but it was not statistically different. So Prolia has to be used forever. So what I typically do, the patient's been on it for a while and has done well, I may give them a single dose of zoledronic acid, and others do this too. There's no data to support it, but it kind of makes sense to sort of consolidate what they have and hope that they don't lose it. Forteo, so we use it after a period of time of being on a bisphosphonate, or as a first line for severe osteoporosis, particularly with multiple compression fractures. I tend to use it in young patients who have glucocorticoid-induced osteoporosis with multiple fractures, and then when they come off the glucocorticoids, I may not treat them any further. Prolia is best in the elderly or after a period of bisphosphonates, and Forteo, the patient who continues to be at high risk. Prolia has a more potent anti-resorptive effect than zoledronic acid. What that means is it may cause osteoporosis of the jaw more than zoledronic acid, but we don't have that data yet. All right, so this is just general stuff that we talked about. So in summary, we should start treatment in postmenopausal women who have osteoporosis, meaning they have hip or spine fracture or T-score less than minus 2.5, or they have low bone mass with a 10-year risk of fracture, at least 3% for hip or 20% for any fracture. And then after 3 to 5 years of bisphosphonate, you need to take a good look at what their ongoing fracture risk is. If it's high, continue treatment. If it's not that high, stop. And then after discontinuation of bisphosphonates, repeated DEXA. If they're still in the osteoporosis range, you can do it every year. The insurance will pay for that. If they're not in the osteoporosis range, check again in 2 years. And then resume with bisphosphonate or other drug if the fracture risk becomes high again. And that's the end. I wanted to leave time for questions because I was assuming you might have questions. Yes?
Can you go into lots of detail about the interaction of exercise? Is it ever effective to just institute a program of vigorous, elevating exercise like you described, versus getting right on building up the bone? So
that's a great question, and it's effective for the hip exercises. It doesn't do much for the spine because the bones that improve are the ones you load, and it's hard to load the spine. You know, probably distance rowers, you know, get increased spine, but it's very hard to increase the spine. So if they have osteoporosis in the spine, the exercise is not going to help very much. But I tend to push that in young women in their 50s who haven't had a fracture. They're in the osteoporosis range. I didn't talk at all about peak bone mass, but you can have a genetically low peak bone mass. So it's controlled, like 85% of your peak bone mass is genetic. And we know that the increased risk of fractures with older, you know, as with age. So, yeah, I mean, I promote exercise for everybody because, number one, it helps reduce things that are going to kill them, which is not the osteoporosis, you know, cardiovascular disease. And if there is a statin abuse, that's it. So, and I have a lot of patients who are very interested in exercise, and it's been disappointing to them how little an effect it has compared to the medications. Yeah.
In the treatment recommendation to screen women with DEXA starting at age 65 unless they have risk factors, are you recommending that anyone?
Yeah. So when to do a DEXA? So the recommendation to screen after 65 is at a bare minimum, like every woman over 65. That doesn't mean that that's when you start screening. So any postmenopausal woman who has risk factors, any of these risk factors should have a baseline DEXA. And I personally don't think it's overkill to do it on every postmenopausal woman because the risk factor profiling is not very sensitive. And then you have a baseline, and then the next question is when do you do it again? Most people would say 2 years. There was a study that came out about 5 years ago that was really actually nice. It kind of predicted if you had a postmenopausal woman with a certain, you know, BMD and T-score, how long would it take for them to qualify, you know, assuming normal bone loss with age. And it was a great study. It was kind of bashed because in the osteoporotic world, we would rather do more DEXAs than less, but it does make sense that if your newly menopausal patient has a T-score of minus 1.2, you may be able to wait for 8 years to do another one. So I think you can use your judgment on that. Yeah. And I should mention also, anybody who has a fracture, I had that list of other reasons to do a DEXA. Yes?
I wanted to make sure I got the point you were making about the vitamin D level.
Yes.
There was a slide that you showed about ideal and those things in regards to the reference range.
Yes.
That's a good question I frequently have. So are you saying that you don't necessarily buy into the reference range or what is the vitamin D deficiency? Could you go through that again?
So the reference range goes for most labs now, it goes from 30 to 100. And that over 100 is when you start getting toxicity. In fact, you can get it even earlier than that. But no one believes that a level of 80 is good or is something we should be trying to achieve. So I mentioned that vitamin D has, other effects. It's a steroid hormone. It gets into the nucleus and changes transcription of hundreds of other genes. So it has a role in preventing or reducing the risk of cancer diagnosis and death from, including breast cancer. The magic number in those studies is about 37. 25-hydroxy-D, above 37, there is no additional protection. And there's a slide I didn't put in, but it's from N. Haynes, which shows all-cause mortality on the y-axis versus 25-hydroxy-D, and it's a U-shape, so increased mortality below 30 and above 50. That's really the only negative study I know that suggests that above 50 may not be so good.
So if you're going to start someone supplementation, how often would you then check it again?
I check in osteoporotic patients annually.
What about in non-osteoporotic patients?
That's a public health question, and I think it's not, I don't think many people would agree with measuring it on everybody, even though we do have a vitamin D deficiency epidemic along with the obesity epidemic, because it's fat-soluble vitamin and just diffuses in the fat stores. There's a lot of individual variability. Their genetic 30% of your 25-hydroxy-D is determined by genes. So
my question: do you treat everyone if they don't have other issues?
Well, yes. Yes, there's good evidence that living at this latitude, if you live at the equator, you can make vitamin D in your skin all year round. Although even at the equator, as I think many people know who've been to Florida during the winter time, they still dress as if it's winter. So there is actually a seasonal variation in 25-hydroxy-D, even if people live at the equator. But they can make vitamin D in their skin. The further away from the equator you go, north, the shorter the window of time that you can make vitamin D in your skin. So at this latitude, it's basically June through August. And forearms and face are not going to do it. So the best skin to make the most vitamin D is the trunk and the legs. So basically you have to be in a bathing suit. And so for people who are lifeguards, or they are outside gardening all day, they might be able to get enough vitamin D in the summer, although the amount of the vitamin D precursor in the skin, 17-hydrocholesterol, the sun shines on your skin and breaks this precursor into vitamin D, goes down with age. So that a 70-year-old has 20% of the precursor as a 20-year-old. So your patient who's out, golfing isn't going to make any vitamin D. And also, the darker the skin, the more sun you need. So melanin absorbs UVB light. And so basically, for people who are not taking vitamin D, they're deficient. And if they're overweight or obese, they're deficient. But not everybody. So I think from a public health standpoint, we can't afford to check 25-hydroxy-D in everybody. So, but if everyone, there was a study actually that calculated that if everyone took around 1,500 units of vitamin D, no one would be toxic and most people would be replete. So for your thin woman, 1,000 units a day is enough for most. The more obese, the more they need. So 2,000 to 4,000 units in an obese person. Did that answer your question?
Yes, thank you very much.
Yeah.
Counts for improving your spine, definitely, but not helping the hip. Why is that different?
Yeah. So there are two basic types of bone: trabecular bone in the spine, and also in the ribs and sternum and skull, and the ends of long bone, which is very metabolically active. And so any bone that's trabecular, like the spine, responds faster to insults and to treatment. So I mentioned that with Depot, Provera, and glucocorticoids, the spine bone loss is very rapid in the first 6 months and then continues. It's also true that the spine responds the best for all of our drugs because it's more metabolically active. And our drugs are working on bone turnover. And the hip, it responds better to exercise just because it responds the most to loading of the bone. Yes, yes. So I said earlier that I encourage all of my patients to do not just little 3-pound weights, but weight training after age 50, because we all lose muscle mass after 50, and that's bad for metabolic issues such as glucose regulation as well. But for falls and bone health, yes, weight training. So if your patient is jogging, it's wonderful for the hips, but does nothing for the upper body. And so you have to load the bone you want to improve. So if you want to reduce the risk of rib fracture, you have to load wrist fracture, you need to load the wrist. Yes?
Questions on the track.
Yes.
So you select U.S.
Yes.
It's only Caucasian.
No. Caucasian, African American, yes. So
the selection only went to automatically with the U.S. and then this is the way.
No, you have to scroll over, and there's African American and Caucasian.
Okay.
Yeah.
And then for the selection of the machine that you use,
Yes.
is that listed on the report?
Yes. So most facilities have Hologic machines, and ours across the bridge, not across the bridge, across the street is Hologic. At the VA, we use Lunar, but it will say that GE Lunar on the bottom or Hologic in big words. So that's easy to figure out. Most of the reports now will do a FRAX for you. They're not always correct, but they sometimes they do it and the patient's osteoporotic and it's really inappropriate because FRAX is only based on hip BMD. And so if you have a patient who's got a T-score of minus 2.6 in the spine, the FRAX is going to give you a falsely low impression of the risk of fracture. Anybody else? Okay, well, if you have questions, yeah.
There is kind of a history of hypogonadism. Do you consider that like another risk factor?
Yes, yes.
Earlier, and if so, how early do you do that? Like if someone goes through anorexia or
yes.
things where it's common that during their reproductive age they weren't making a testosterone, would you start those scans even earlier than menopause?
Right, so that's a good question, and I didn't include anything about anorexia, but it's a very important topic for you all. The bone health in anorexia has been studied for years and years and years and years, and what we know is that, yes, women with hypothalamic amenorrhea get terrible bone loss, but the only thing that helps is regaining weight, and also growth hormone, which is extremely expensive. It's $20,000 a year given by injection every day. It does help the bones. Bisphosphonates, oral contraceptives, estrogen replacement, which you may want to do anyway, don't help the bones. So I think that you can do a DEXA to help motivate your patient, but generally don't treat it because treatment doesn't work. Yeah, so I would do one at the baseline just to have an idea and really try to get the treatment to regain the weight. Any other questions? Okay, well my email is available if you have any other questions later.
Thank you.